Hello, my name is Harsh Mittal. I'm from MAMC and now a final year MBBS. Uh, I'm going to show you how to give an near ideal case of CSOM in ENT practicals. So in ENT practicals, there is a long case, there is a short case, and instruments and X-rays. So the major part of practical is the CSOM long case. In long case, usually most of the people get CSOM, so it's major concern for students, so focus on this a lot. Some people also get nose related like polyps most probably in the long case. Otherwise study other don't spend too much time on other things. Majorly study CSM and polyps, but CSM is most important. So important thing about this is that I am not going to give every knowledge about CSOM. I'm just going to tell you all the points that should be there in their case, and I will explain a little bit about the importance of every point in your case, because if you don't know the importance of the points, then the examiner will kill you. Not literally. If you are in a hurry, then I am showing the case in one go. You can just screenshot it. It has all the points. Now after this is over, I will explain each and every point in detail and what is the importance and what all your questions can be asked related to that. By the way, it's not flawless, so if you find any point to be added or deleted, you can do that according to your college. So now I will start the explanations. So since many of you might not attend the posting because of this pandemic, I will tell you a little bit about what the usual case is. So you write the name, age, sex, address, occupation. I also prefer to write the socioeconomic status because it has importance, because CSOM is more prevalent in the lower socioeconomic status people. History given by, usually it would be an adult, so you don't have to write who gave the history. Then you need to write about the chief complaints. So there are majorly two chief complaints that a CSOM case will present as. First, there will be discharge from the ear. It could be left, right, according to your case, and then loss of hearing. So this is the one of the silly mistakes. Don't write loss of hearing. Loss of hearing is very absolute, so you have to write decreased hearing. Then you have to write since when, obviously. Then history of presenting illness. Patient was apparently well 6 months back, for example. Then you have to start describing each point in detail. One important point, that if you are mentioning the socioeconomic status, then you should be well aware with the the way in which you take the socioeconomic status, the Kupuswamy and modified Kupuswamy and BG Prasad etc. Otherwise, so when you start describing this, you have to go in a flow. So you say like, there was left ear discharge since 6 months, which was insidious in onset, intermittent in nature, mucopurulent, odorless, non-blood stained, and profuse amount, and was aggravated by common cold and relieved by medications. I don't think there is a need of mentioning color, so cut it. After you have described discharge, there will be questions. So first question will be what's the difference between continuous and intermittent discharge. So basically in the safe CSOM, it will be intermittent, which is usually along with the infection like common cold, but in the unsafe CSOM it will be continuous. Then nature, it can be mucoid, serous, mucopurulent. So there are different pathologies and etiologies of all these conditions, so you should be well aware of that. Safe CSOM is usually odorless, but unsafe CSOM is foul smelling. Blood stained, it will be mostly unsafe, and safe CSOM is not blood stained. Once you mention this, they will probably ask what are the different types of bloodstream discharge from the ear. So you have to be ready with the DDs of bloodstream discharge. Then amount of discharge. They will ask how did you say that it was profuse or it was mild or moderate. So there is different things that you can ask a patient. If the discharge wets the pillow or dribbles out of the ear canal, then it is profuse. If it is present in the ear canal, then it is moderate. And if the patient can wipe it off in 1 or 2 swabs, then it is mild. Then aggravating factors are usually infections of ear, nose and throat, and water entry into the ear canal. So we also have to tell the patient after the treatment that he shouldn't allow the water to enter the ear. In relieving factors, you mostly have to tell about the eardrops. At this point, the Viva will mostly go around the difference between the safe and unsafe CSOM, unless you say some terrible terms and then mess up the Viva. So don't be hi-fi, stick to the basics. Now we talk about decreased hearing. So you have to say the patient has decreased hearing in left ear since 5 months, which is so if there is bilateral hearing, then you have to tell left more than right or right more than left. If it is unilateral, you can talk about 1 ear only. In CSOM, mostly it is insidious onset, so don't say abrupt. Then you need to quantify the magnitude of the hearing loss. So you need to tell about if the patient was able to hear whispering, normal conversation, telephone ringing or doorbell. It is very well given in the book about various degree of loss at different things. And then you have to ask if the patient is able to understand the conversation or not. And the examiner might ask you, how did you elicit left more than right? Then you can say that the patient preferred right ear for telephonic conversation, so left ear was more affected. The questions at this point will be about loss of hearing, the grading of loss of hearing, although it is usually asked during the examination of ear. Then you have to ask about history of trauma, what type, bleeding at that time or not, or hearing at that time of trauma. Then now we come to the complication history. So there is a specific way of going about the complications history. So first you have to rule out the extracranial, then intratemporal, and then the intracranial complications. You should remember all the complications on the tips, otherwise it will be very difficult to pass. So we classify complications into intracranial and extracranial. Extracranial is intratemporal and extratemporal. So firstly we start with the extratemporal. It should be extratemporal. I have written extracranial. In the extratemporal complications, there is Sitley's abscess, Resolved abscess, Lux abscess, subperiosteal abscess. So basically they will present as swelling around the ear or neck. Basically swelling or pain in and around the ear or neck. There is a problem that the Sitley's abscess, in one book it is written that it's the towards the occipital side. When there is an abscess formation, it is called Sitley's abscess. But many examiners say that it is along the posterior belly of the digastric. So then we start with intertemporal complications. Important one is mastocytitis, which has been ruled out by the swelling in and around the ear. Then comes labyrinthitis. We rule out spinning sensation, don't say vertigo. Then we talk about petrositis. In petrositis, there is a Grade-Nigo syndrome, which is a triad of discharge from ear, diplopia, and deep orbital pain. Don't say retroorbital pain because we can't know that. So say deep orbital pain, and we have to rule out deep orbital pain and double vision. Then there is facial nerve palsy, which is ruled out by asking if there is any problem in eye closing, eating, or deviation of mouth, or weakness in the mouth, face matlab. Then in the intracranial part, we again have many abscesses: epidural, subdural, subarachnoid, then cerebral abscess, cerebellar abscess. Then we come to lateral sinus thrombosis and aortic hydrocephalus. These are major intracranial complications. So we rule out fever, headache, seizures, neck stiffness, photophobia, and projectile vomiting. So these abscesses around the meninges and many all intracranial complications have fever. So we rule out that. Neck stiffness for meningitis. In lateral sinus thrombosis, there is special type of picket fence fever. So it's important point to that they might ask. Then seizures in cerebral abscesses, photophobia and projectile vomiting for meningitis. You can also ask about balance to rule out the cerebellar abscess. This was the major portion of the history. Then we come to the past history. We ask hypertension, diabetes, TB, surgical intervention, any ENT related problem. Hypertension, diabetes, TB have surgical related importance, and ENT problems tells about there might be an infection that migrated from nose or throat to the ear. Don't mention blood transfusion. Then write about the personal history, socioeconomic status. As I told you, it is more common in the lower socioeconomic status people. And then treatment history. Later in the management, I will tell you that first we give the ear drops. We make the ear dry. That is, there shouldn't be any active infection. After the ear is dry for 6 weeks, then we can consider it for surgery. So if there is no patient, then I will say that it's better to write the patient was given treatment and the ear is dry now for 6 weeks, and now we can do surgery in this patient. Some examiners like to listen a short summary after the history is complete and provisional diagnosis, but I never did that. So we now shift to examination of the ear. So you have to start with the basic. Patient is sitting comfortably. Patient is conscious, cooperative, oriented to time, place, and person, and is examined in a well-lit room with proper consent taken. Now there is an importance of conscious, cooperative, and oriented to time, place, and person, because it again rules out the possibility of intracranial complications. Then we do the general examination, mention the heart rate, respiratory rate, blood pressure, temperature, pallor, rectus, sinus clubbing, lymphadenopathy, edema. Then do systemic examination, respiratory, CVS, and CNS. CNS examination is important because to rule out the intracranial complications. No questions are asked up till this point, and then major questions will be asked from the local examination of the ear. So there is a logic behind the way of local examination. So first we will inspect the ear, we won't touch. Okay, so in inspection we say comment about the pinna, no abnormality detected bilaterally, and then we shift to the ESC. If the patient is having mastoiditis or furunculosis in the external auditory canal, then the patient will scream if you put speculum inside the ear. So first we do without speculum examination, and then comment no abnormality, and then we do the oral examination. Without speculum, mostly cartilaginous part is observed, and in oral speculum we see mostly about the bony part, and then we see the tympanic membrane of the ear. You should do 3-finger test before doing the examination of the tympanic membrane or before introducing the speculum ideally. So write 3-finger test around this point, and then we write the tympanic membrane examination. In tympanic membrane examination, the most important thing is the diagram of the tympanic membrane. The examiner usually look into the diagram and finally found a mistake. So be careful with the diagram and label it nicely. So first we need to comment about both the pars tensa and the pars flaccida part of the tympanic membrane. A question that they might ask you is that which ear will you examine first, the abnormal or the normal ear? So you have to examine the normal ear first. There are a few reasons for this. Firstly, we like to see the normal physiology, the normal state of the person. Okay, and also it is to gain the confidence of the patient, because if you introduce it in the abnormal patient, abnormal ear, then the patient will experience pain and he won't let you examine the normal ear. Also, if you first examine the abnormal ear, then you might actually introduce the infection into the normal ear while examining it. So first we examine the normal ear, and then we examine the abnormal ear. So you have to say that pars tensa is seen with central perforation involving two quadrants with well epithelialized margin with foreshortening of malleus. It's better to comment about the color of pars tensa also. Now when you tell about number of quadrants involved, then there will be question about the classification of perforation into mild, moderate, subtotal, and total perforation. So read about that. Importance of well epithelialized margin is that in chronic cases the margin of the perforation gets epithelialized. So if you are seeing a CSOM case, that is chronic suppurative otitis media, then it will be well epithelialized. It won't be a fresh margin. Foreshortening of malleus, let me explain the concept. So basically when there is a perforation, the malleus lose the connection with the tympanic membrane, so it gets medialized, but we are seeing it at an angle, therefore it looks like the handle of malleus got shortened. This is called foreshortening of malleus. So it's usually seen in subtotal or total perforation, so don't mention without in a small perforation. Then you can also comment on the middle ear, if it is visible or not, and if the mucosa is pink or congested, or if there is any pus seen. Also you can comment about bony landmarks that you are able to appreciate. Then you have to say there is no abnormality in pars flaccida. So they may ask you what are the possible abnormalities, which could be perforation or retraction. So you need to be well aware with the grading of retraction of tympanic membrane, and it is different for pars tensa and pars flaccida. So read about TOS and SAID's classification of retraction. As I said, you have to do 3-finger test. It should be done before examination. So in 3-finger test, don't say 3-finger test negative or positive. Say that there was no mastoid tenderness and no tragal tenderness. Then they will ask you, how did you elicit this? Then you have to say that, sir, I did 3-finger test in this patient. Then before starting with the facial nerve examination, you need to tell about the tuning fork test. So we do 3 tests: Rene's, Weber's and ABC. Rene's should be ideally done with 256, 512 and 1024 Hz tuning fork, but majorly if you do with 512, it's okay. When we start with the tuning fork test, the questions start with what is tuning fork. So you should be well aware with the name of tuning fork, what are the parts of tuning fork, and how to hold a tuning fork. Also you should know how to do Rene's, Weber's and ABC tests. Also what are the interpretation of Rene's, Weber's, ABC, and what are the, in Rene's they can ask what is the level of deafness if 256 is negative but 512, 1024 are positive. So you have to tell you have to know what are the deafness level at different hertz. Then in Weber's, the way you have to say is lateralization towards left or right. Don't say positive or negative. Also in Weber, they ask you what are the position at which you can keep the tuning fork. So basically it's along the midline, anywhere on the face. During the ABC test, don't forget to close the EAC, otherwise it will be a huge blunder. Also, they ask about why 512 is considered ideal. 512 is ideal because there is less vibration and decay time is less. So basically, the 256 Hz tuning fork has more of vibration, so the patient might be appreciating vibration instead of sound, and in 1024 the sound die off quickly. After tuning fork, we do the facial nerve examination, which is very important. So do the motor functions. The taste function and sensory question are mostly for the viva. Then you can check for the cerebellar involvement, or you can do it along with the CNS examination in the systemic examination. Then you have to comment about nose and sinus and oral cavity, because infection in these area can migrate to the ear through the eustachian tube, and lymph node if there is an enlargement. Then you have to give the diagnosis. So my patient Ramu Kaka, 56-year-old male, farmer by occupation, have left-sided chronic otitis media, tubotympanic type with moderate conductive hearing loss. So if you have survived the history and examination, the examiner might ask you the management of this patient. So it's mostly viva, you don't have to write anything. So first we have to say that we will do examination. So in examination, there are general examination that we do for any surgery, so you can write about that. Then disease specific examination. The most important examination is PTA, and if there is any conflict between tuning fork and PTA, then the tuning fork findings will be preferred. Also, if the patient is less than 5 years, we do BERA. When we do PTA, there is also a test known as patch test, in which we take a paper and then apply it. We take not a paper, it's some kind of membrane, and then we put it on the perforation, and then we see improvement. Patch test is majorly done to see prognosis, and the material of that thing is important. If the patient has active pus in ear, then say pus culture or sensitivity, don't say it otherwise. And examination under microscope, this is usually not needed in case of safe CSOM, and it is required in unsafe CSOM. Also, there is no need of imaging in CSOM, so don't say. So if the patient has pus, so you will prescribe ear drops to clear the infection and make the ear dry, and you have to wait till 6 weeks before the surgery. So the criteria for doing surgery is minimum 6 weeks there should be dry ear without any medication. So then they ask what surgery you will do, you have to say tympanoplasty. Then they might ask you what is the difference between tympanoplasty and laryngoplasty. If you only repair the tympanic membrane, you are doing laryngoplasty. But if you are also checking the ossicular status and repairing the ossicles, it is tympanoplasty. So then the questions are around the types of tympanoplasty. The classification is given well in the book. Also the approach, so there are 3 approaches: post-auricular, endoral and endomeatal, and it is different from the technique of the surgery. In technique there are underlay, overlay and also interlay, but don't say interlay. Majorly you have to say underlay and overlay, and we usually do the underlay technique in the OT. Then they will ask you what is the minimum age. It is 12 year, and if the patient is 12 year, the surgery can be done only if there is bilateral CSOM affecting the school performance. Before the surgery, we should check the adenoid conditions, and it should be performed under general anesthesia. Usually, it is done under the local anesthesia. So basically, this covers all the topics, all the headings that you have to say, and all the points that should be covered. There might be some things missing, so add or delete according to your college or your professors. Also, the viva will go according to what you say. So if you take big terms in front of the examiners, so the viva will go very terrible. So try to stick to the basics and don't say things that you don't know. All the best.